Okay, we're going to get started. So welcome, everyone. Welcome to Immunotherapy, Immune-Based Therapies, Vaccines, and Current Research with Dr. Leisha Emens. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at SHARE. So before we begin, I'd like to tell you just a little bit about SHARE. We're a 39-year-old nonprofit organization that helps people through breast or ovarian cancer, offering the support of those who've been there. Leisha Emens is an Associate Professor of Oncology at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center. She received her MD and PhD from Baylor College of Medicine and completed her residency training in internal medicine at the University of Texas at Southwestern before coming to Johns Hopkins in 1998 for a fellowship in medical oncology and hematology. Dr. Emens specializes in cancer immunotherapy, and her research focuses on the development and implementation of breast cancer immunotherapies, including vaccination strategies and immune checkpoint blockade, in combination with traditional anti-cancer therapies and newer biologically targeted therapies. She's a member of the FDA Advisory Committee on Cell, Tissue, and Gene Therapies, and on the editorial boards of the Journal of Clinical Oncology, Cancer Research, and the Journal for Immunotherapy of Cancer. Dr. Emens has dedicated her career to finding ways to harness the immune system to fight cancer. She believes that immunotherapy will one day revolutionize cancer care and ultimately prevention. But she also acknowledges the enormous challenges of making this happen. Dr. Emens, thank you so much for being here.
Thank you very much for the invitation. I'm delighted to be here today to review some of the really exciting advances in immunotherapy for cancer. I'm going to use breast cancer immunotherapy as a model. We also have a budding program in ovarian cancer immunotherapy here, but some of these basic concepts I'm going to discuss are relevant to all cancer types. I'm going to show a lot of detailed science slides, and I don't want you to get bogged down into the details, but what I'm going to try to do is get across some major concepts to you guys. So that's the goal of the talk, is just to give you concepts so that when you read about things in Time Magazine and Newsweek, you can really appreciate and put that into the context that you might not otherwise have by the fact that you've heard this seminar. So these are the conflict of interest that I'm required to disclose by the institution, and basically it discloses a licensing agreement between a company that has acquired the rights to our vaccine. I get research funding from a variety of companies, as well as serve on the advisory board or as a consultant to others. I'm going to talk about some investigational use of several drugs, including 2 vaccines, one of which is NeuVax, one of which is GVax, our vaccine, as well as the investigational use of monoclonal antibodies specific for CTLA-4. This is an antibody like this is approved for melanoma. It's called Yervoy or ipilimumab, as well as antibodies specific for PD-1 or PD-L1. There are antibodies approved for lung cancer and melanoma, pembrolizumab or nivolumab. I'll talk for breast cancer about pembrolizumab and another agent called NPDL3280A, which now has the name atezolizumab. So all these monoclonal antibodies have pretty gangly names. I apologize for that. So for the talk, I'm going to give you a brief overview of the immune system and what its purpose is, talk a little bit about T cells, which are the ultimate target of immunotherapy, regardless of what the target of the drug is. With immune-based drugs, we think ultimately what we're trying to do is get T cells to work better. I'll review a little bit of data on 2 vaccines, one of which is our vaccine, GVax, the other of which is NeuVax, which is in phase 3 trials. And then finally talk a little bit about immune checkpoint blockade, which has really made everyone excited about immunotherapy across multiple tumor types and has galvanized both the immunotherapy community and the oncology community and raised great hope for the future for all of us as well as patients everywhere. And then I'll conclude by focusing on just the overriding messages with breast cancer. So this is the first really key concept to understand, and the purpose of your immune system is to tell what's you from what's not you. Your immune system is designed to attack things that it can perceive as threats, but in the context of doing that, it also has to keep from attacking your own body. So self, non-self discrimination is the hallmark of the immune system. This allows it to avoid self-destruction, and when that regulatory milieu breaks down to keep it in check against your own tissues, you develop autoimmune disease like rheumatoid arthritis or lupus or other diseases. In addition to avoiding self-destruction from your own immune system, it exists primarily to protect you against threats. First, against exogenous threats. These are typical of infectious invaders like viruses or bacteria, but also against endogenous threats, and this includes, for the purpose of this talk, cancers. One of the challenges of harnessing your immune system for cancer therapy is that cancers come from your own tissues. So your immune system naturally will have a tendency to view your cancer as normal tissue or as self. There are subtle changes on cancer cells that can be recognized by the immune system, so this can be dysregulated self, and it's those features of malignant cells that we think can be targeted by their immune system in order to activate the immune system to attack and destroy the cancer. So two major purposes of self-non-self discrimination are to avoid self-destruction through autoimmunity and to protect against threats, either infections or threats from within. There's two major functional arms in the immune system that allow it to do this, and this is a lot of information. The innate arm is non-specific. It serves to sense danger, so it's your first line of defense when a bacteria, like if you cut yourself and a bacteria enters the cut. There are a number of cell types shown here that help mediate this innate immune system, as well as a number of soluble things that circulate in the blood. So the innate immune system senses this and then can interact with what we call the adaptive immune system, and that kind of makes just that word adaptive makes you think that it adapts to whatever's coming its way. And because of that, it's an apt name because it is antigen specific. So this part of your immune system responds to things in a very highly specific way by virtue of specific receptor proteins that can recognize foreign markers on viruses or bacteria or mutated proteins on cancer cells. And these antigen-specific immune cells serve a specific protection and threat elimination function. They include these T cells that I referred to at the beginning. There are helper T cells that support many aspects of immunity. There are cytotoxic T cells, which act kind of like the smart bomb of the immune system that destroy virally infected cells or cancer cells. When you think about the immune system, we always think of vaccines for infectious disease. So you get vaccinated to prevent yourself from getting an infection at a subsequent exposure. That's possible because your immune system has memory. It learns to recognize something that's potentially dangerous and is poised to recognize that as a future date, at a future date. So there's a very small population of T cells that hang around that have been educated to recognize threats that can come into play and become activated at the first sign of trouble. There are bad T cells that can accumulate in cancer called regulatory T cells. These are Tregs. And then finally there are B cells, which is a different type of cell, and it secretes antibodies. And for those of you who are familiar with Herceptin, Herceptin is an antibody type drug, and we capitalized on these antibodies that the body can make to turn them into drugs like Herceptin or Rituxan for different types of cancers. It's B cells that ultimately make these antibodies. Antibodies are very specific for proteins. So both the T cells and the B cells and antibodies are very specific and constitute the adaptive immune system. The innate immune system is that sensing, so the sentinel cells that are not specific, they just recognize danger and alert the immune system so that the adaptive immune system can kick in. This compares and contrasts the innate and the adaptive immune response in terms of various features of it. As I mentioned, the innate immune system is nonspecific and senses danger. In contrast, the adaptive immune system is highly specific. Antigens are like tags on bacteria or viruses or cells that the immune system recognizes. For innate immunity, antigens are really unnecessary because the innate cells recognize other markers of danger. For the adaptive immune system, it's highly specific, so these antigens or tags are required for activation of the specific cells. Innate immunity has no immune memory. It responds very quickly, and the response does not last long. So there's no memory, the kinetics of response is very fast, and the duration of response is very transient. So it's kind of like lighting a match to start a fire, and then the fire would be the adaptive immune response. Here, immune memory is necessary. The kinetics of the response, this response evolves over time, so it takes a while for the adaptive immune response to develop, and that will become relevant with some pictures that I show you later. And importantly, the duration of the response with the adaptive immune system is durable, so it can last a long time, and that is by virtue of this phenomenon of immune memory. So the key differences between those arms of the immune system, and remember, this innate system becomes activated to engage the adaptive immune system in a specific way to protect you from these threats. So this is a very complicated picture. I'm not going to spend any time on this other than to show it to you, and just shows the innate immune system on this side, the adaptive immune system on this side, and shows you that they interact. So it's kind of like an orchestra, really. They interact in a very highly coordinated way to ultimately kill cancer cells, shown down here. And that's enough detail of that. So there's really a collaboration between this highly specific part of your immune system and the non-specific part to result in efficient killing of cells that are bad. And then another key concept is that the T cell, and I've alluded to this before, it's really the key player in tumor rejection. So if you hear about PD-1 agents that target the PD-1 pathway, those drugs target the PD-1 pathway, but they do it ultimately with the goal of making T cells work better. So T cells are really the target of immunotherapies. We think that they're critical for tumor rejection. So we'll just talk about breast cancer and the immune system as an example of how the immune system interacts with tumors. For the longest time, people didn't think that breast cancer was an immunogenic type of tumor. The tumors that classically are considered immunogenic are melanoma and kidney cancer, and people just thought breast cancer, as well as lung cancer and some others, really weren't very immunogenic. And this is data that just shows you that breast cancer can induce T cells, or adaptive immune responses. This is a picture of an untreated breast tumor that's been surgically removed, and it's stained for a marker on T cells called CD3. And you can see that there's a ring of T cells surrounding this tumor. So they're surrounding this tumor, attracted by subtle alterations on the tumor. And you can see that there's a few T cells within the interior of the tumor, but by and large, they're really surrounding the tumor. So a breast cancer can induce a specific T cell response. This has become a very hot area of research. There's an increasing number of reports that examine the nature of T cell infiltrates within breast tumors. It turns out that cancers with poor prognostic factors tend to have higher T cell infiltrates at diagnosis. And to a large degree, that makes good sense. These are tumors that are lymph node positive, so they've already engaged into areas where your immune system is located. They tend to be ER negative and PR negative, as well as high grade. There's these good T cells, CD8 positive T cells that are present, and there's also these bad T cells, the FOXP3 positive regulatory T cells. And the ratio of these good to bad T cells can actually predict clinical outcomes. So if you have higher good T cells relative to bad T cells, you're more likely to have a complete pathologic response to neoadjuvant chemotherapy. You're more likely to have longer progression-free survival, and you're likely to live longer than if you had a low ratio of good T cells to bad T cells. And that's just shown here in these survival curves. So stromal CD8 positive T cells within the tumor, if you have lots of them, your survival is up here. So this is survival on this axis. So here's 100%, here's 50%. So if you have lots of T cells, you survive better than if you don't. In contrast, if you have lots of regulatory T cells, you survive less well than if you have less. So more CD8 positive T cells is good, and more regulatory T cells is bad. So this just looks at survival. This looks at the balance of CD8 positive T cells to Tregs before neoadjuvant therapy. You can see these two curves basically overlap, and after neoadjuvant therapy. And you can see that this unmasks a difference, that if you have a good ratio, you do better than if you don't have a good ratio. So just another study looking at how this ratio of good to bad T cells can predict clinical outcomes. So it's really interesting that we've been giving cancer therapies for a long time without really thinking about the multitude of different ways they can work, and it turns out that a lot of standard cancer therapies actually have immune-based activity. And this looks at paclitaxel or Taxol, which is a chemotherapy we use both preoperatively and for adjuvant therapy, as well as therapy for metastatic breast cancer. It's also used in ovarian cancer. If you give a patient newly diagnosed with breast cancer a dose of paclitaxel before surgery, and then look at what happens to the tumor, you can see that before the Taxol, this is the tumor, and there's just a few scattered T cells, as in these maroon cells within the tumor. After the paclitaxel, you can see that the tumor really becomes loaded with these T cells. So the Taxol itself can actually induce the accumulation of good T cells within the breast cancer, and we think it in part works by engaging the immune system. There are other chemotherapy drugs that can also work in part by engaging the immune system. It's interesting because typically you think of chemotherapy as suppressing your immune system, but what it does is it suppresses the innate immune cells that fight infection. So when you talk about your blood counts dropping low with chemotherapy, typically it's the neutrophils, or a marker of innate immunity, that are that first line of defense at infection, and these are the adaptive cells. So they can actually, chemotherapy can sometimes help promote the generation of good T cells. We don't need to look at that one. So T cells recognize cancers in a really specific way, and I talked a little bit about these tags. And these tags, the scientific term for them is antigens, and there's different types of antigens that a T cell might be able to recognize. There's a lot of data out there suggesting that tumors who are more highly mutated might be more immunogenic, and that makes good sense because the mutations form a protein that is perceived as foreign to the immune system rather than self. And some of those novel cancer tags or antigens include mutated KRAS, which is an oncogene in pancreas and lung cancer, P53, which is one oncogene that's mutated in some hereditary cancers, and then mutated antigens from chromosome breaks that are common in leukemia, like BCR-ABL. Another type of cancer antigen that's not mutated but is overexpressed is HER2, which is the prototypical example of an overexpressed normal protein. So HER2 is really a highly validated therapeutic target, particularly in breast cancer, but now also in gastric cancer. It's overexpressed in about 20% of breast cancers and expressed at lower levels in more of them. And it really actually is one of the best validated tumor antigens out there. And it's an example of an overexpressed tumor antigen. Telomerase is an enzyme that regulates how long cells live. The scientific name for that sometimes is HTERT, so that is something that's overexpressed in many cancers as well. Sometimes you can have proteins that are expressed during fetal development that are only expressed in development, and they're downregulated as an adult, so the immune system actually never sees them. Because of that, they're viewed as foreign by the immune system, so MAGE is an example of that. You can have, similar to that, in other ways, expression of a protein outside of a site hidden by the immune system. And then finally, you can have some proteins that are specific for certain tissues. For breast cancer, mammoglobin is an example, and that would be something that's probably secreted into milk. So this just takes a look at how tumor antigens on the surface of a tumor cell are seen by T cells. So here's a T cell. It has on its surface a receptor that's highly specific for one of these tags. And remember, I said the immune system, its job is to recognize self from non-self. So it has to view, for T cells, it has to view the tag in the context of a self protein. And that's this protein here. This is MHC. These MHC molecules are the proteins that are matched when you get a bone marrow transplant. So that kind of makes sense. You want to make sure that if you give a transplant to somebody, their body won't reject it. So you have to match those self molecules so that transplant is seen more as self than not self. So for purposes of this discussion, this tag is seen bound to a self molecule. So you're seeing this tag in the context of self by the T cell receptor. This gives the T cell signal 1. When I was learning all of this way back in the 80s, we learned that there's 2 signals in a very simple view required for good T cell activation. A tumor cell is not able to give a T cell the second signal. So in the absence of signal 2, the T cell actually gets shut down. It does not become activated, and the T cells can't react to the tumor. So you can restore that signal 2 in 2 ways. This is our vaccine platform, how we've developed the whole cell vaccine called GVax. You can either genetically modify a tumor cell to express that signal 2 molecule on the surface. So now the T cell can see the tag in the context of self, as well as get signal 2. Or you can genetically modify the tumor cell to secrete a type of hormone that when it's injected, for example, intradermally underneath the skin, it can attract cells that can then activate the T cells. So these cells are kind of like the orchestra leader for your immune system. The scientific term for them is dendritic cell. And they really are professionally programmed to activate strong immune responses. So kind of like Pac-Man, these cells come into the area where the tumor cells are vaccinated. They're attracted by this hormone. And like Pac-Man, they gobble up bits and pieces of these tumor cells and break them down into these tags and present the tag to the T cell. And they normally have signal 2 molecules, so they get signal 2 and the T cells get activated rather than shut down. So this is our vaccine platform. We use tumor cells that secrete a hormone, inject them underneath the skin after they're radiated so they can't grow, and these Pac-Man-like cells act like the orchestra leader, come up, activate the T cells, and you get good T cell expansion. So we've tested this in a mouse model. You know, you can't take things to patients until you try to provide some proof of principle in the lab, so a lot of times we use a mouse model. And we have a really good mouse model of breast cancer. These are mice seen on the right side that express the RAT-HER2 protein under the control of a small gene sequence that drives expression of RAT-HER2 specifically in mammary tissue. Because of that, it's an oncogene. These mice spontaneously get breast cancer just like people do. So we took one of those tumors and chopped it up and made a cell line that we can continuously grow and culture to use in experiments. These mice are basically derived from the mice on the left side of the slide, these FEBN mice. So these mice and these mice are, for purposes of this discussion, genetically identical, except for these transgenic mice have HER2 and these mice don't. Because these have HER2, they get those spontaneous breast cancers, but as they develop, their immune system develops seeing RAT-HER2. So it sees RAT-HER2 as self, not as a foreign rat protein. These mice never see RAT-HER2, so they see RAT-HER2 as foreign, and their immune system should attack it pretty easily. For these experiments, our vaccine is basically a type of cell, a fibroblast cell, that can secrete that hormone, which is called GM, or the same cell that both secretes GM and delivers HER2. If we take the tumor cells, give these mice a tumor, so there's like a ½ centimeter sized tumor on that little mouse, and then vaccinate with the control vaccine where there's no HER2, the tumors just grow. If we give the same size tumor a vaccine that has both the hormone GM and the HER2, you can see the tumors initially stabilize in size. So these controlled tumors are still growing, these are slowing down, and then they start to shrink. And you can actually cure 100% of these mice just with a vaccine by itself. And it's because these mice see HER2 as foreign, not as self. In stark contrast, if you look at these HER2 mice, they see HER2 as self. And if you give either the control or the HER2 vaccine, the tumors grow out at the same rate. So the vaccine doesn't work at all when tolerance is present. And we think this is the situation in patients more than this. So our goal is to find things to combine with the vaccine to separate these two curves out and to try to achieve cure, as you can see over here. So we've talked a little bit about signal 2, and actually I presented a pretty simple picture of it, and it's actually way more complicated than that, which is good news and bad news. The good news is the complicated nature of it gives us a lot of targets for drug development that should have some ability to help people. So this looks at signal 1, it's shown with the tag in the context of self and the T cell receptor. Signal 1 is being driven to the T cell, as shown by this arrow, and then this is signal 2. So you've got the positive part conferred by the CD28 and a negative part by the CTLA-4, and it's the balance between the positive and the negative that determines the net signal too. So if the positive activation is stronger, it's a positive signal. If the negative activation is stronger, it's a negative signal. There are other parts of signal 2. So there's this CD28 pathway, there's this PD-1 pathway, there's this ICOS pathway. All of them have these positive and negative components of them. There's also this TNFR pathway. So this is actually sort of like the light switch in your dining room at Thanksgiving, where you can dial up the lights or dial down the lights. And as you dial this up and down by engaging these different proteins, you can adjust the strength of signal 2. It also gives a number of different ways we can target T-cell activation, antibodies specific for PD-1, CTLA-4, different members of this protein, PD-L1, etc. So things are complicated. So the next key concept is that this immune tolerance that I showed you in the mice, it's a major barrier to tumor immunity in patients. We've got these Tregs that accumulate in patients as tumors grow and progress. There's a second type of cell that's emerged onto the scene called a myeloid-derived suppressor cell, or MDSC. It also dampens, acts like a wet blanket over the immune system. The T cells that are present are relatively weaker T cells than T cells that might be present that could recognize an infection because of a process the immune system goes through of making sure that you can't react to your own tissues. If you don't get enough positive signal 2s, it doesn't work so well. If you have too much negative signal 2s, it doesn't work so well. Sometimes the T cells, although they get made, they can't get to the tumor, right? And if you remember that picture of that tumor, that most of the T cells were around the rim of the tumor and actually not getting in. So you can have ineffective trafficking of the T cells to a tumor site. And then if the T cells can get in, the tumor microenvironment tends to be quite suppressive. There's a lot of soluble factors that help keep the T cells shut down in the tumor microenvironment. So this just looks at that same vaccine, the HER2 GM vaccine in the new mice. Remember, it doesn't work at all in those mice. And looks at whether we can make it work better by adding a chemotherapy drug, cyclophosphamide, or an antibody that's like Herceptin. And if you look here, if you give those mice tumor just like we did before and you give the vaccine by itself, all the mice come down with the tumor pretty quickly by 25 days. If you add a low dose of cyclophosphamide to get rid of those bad regulatory T cells, you can actually cure around 10% of the mice just with the vaccine. And you can see that you delay the tumor outgrowth as shown by this space. If you add an antibody for HER2, you delay it a little bit more and you can cure roughly 30% of the mice. And if you add them all three together, you delay it the most, shown here. So at 50 days, you're at a fair number tumor-free, and you can cure about 55% of the mice. If you look at the T cells that you get with each of those, you can see if you give all three things together, you get the most T cells. So the higher up it is, the more T cells there are. So this is the vaccine with both antibody and chemo. This is the vaccine with just chemo. This is the vaccine with antibody. And the vaccine by itself is really pitiful. It doesn't give you very many T cells at all. So the magnitude of the T cell response is a pretty good parallel to how well the mice do with the different interventions. We tested this in patients where we gave patients with metastatic HER2-positive breast cancer our vaccine with both cyclophosphamide and Herceptin. This was a follow-up trial to one that we'd done in ER-positive breast cancer patients where we gave the vaccine with only cyclophosphamide as well as some doxorubicin. These are graphs of HER2-positive T cells that secrete two different cytokines. So this is just a marker of good T cell activity, and this is the percentage of T cells. So you can see that with vaccine by itself, as shown here in this solid line, you get a very slight increase in the T cells. If you give cyclophosphamide before the vaccine, you get more T cells. But if you give both cyclophosphamide and Herceptin with the vaccine, you get a very nice increase in the number of T cells that you get. And that's true with both those that secrete TNF as well as those that secrete gamma interferon. So Herceptin is a really nice immune modulatory antibody and can augment immune responses in several different ways. This looks at clinical outcomes in these two trials. So the first trial was the vaccine with just cyclophosphamide and a little bit of doxorubicin. in 28 patients that were ER positive. If you look at the group overall, their survival was 36 months. One of the ways that we looked at whether the vaccine was changing immunity is that we had little pieces of the HER2 protein that we could do a TB type of skin test with. So we placed the HER2 peptides, and 2 days later we'd bring the patient back and measure the redness and the swelling present at the site. That's called DTH. So in the maroon are patients that developed a positive DTH reaction to those HER2 peptides after vaccination, and the dotted line is people that did not. So the immune responders had an overall survival of 56 months relative to the non-responders that had an overall survival of 30 months, and this was statistically significant. If it's less than 0.05, it's a good sign. If you look at the HER2 trial, only 20 patients, the overall survival for the group was 42 months, and the immune responders had a survival of 70 months relative to the non-responders, which was 29 months. So the caveats here are that they're very small numbers of patients, but it's 2 different breast cancer subtypes, similar readout, similar intervention, and it really is promising in that if you develop immunity to the vaccine, you may be likely to do better. And we think that this provides the basis for moving forward into randomized trials to really prove if this is true or not. So this is an exploratory analysis. This just reminds me to talk a little bit about NeuVax. This is a HER2 peptide vaccine. So similar to here where we use HER2 peptides to look at skin test reactions, here you're using a HER2 peptide to actually vaccinate. And it turns out that if you give this vaccine to patients who are newly diagnosed but do not have stage 4 disease in an attempt to prevent relapse, you do get a little bit of benefit both in patients as a whole, from 80 to 89% disease-free survival, as well as in patients that express low levels of HER2 from about 78 to 88% survival. So this is more in line with how we think of vaccines. These are patients that have no evidence of disease in their body at the time because they've had surgery and adjuvant chemotherapy designed for cure, but they may be at risk for relapse. So the purpose of this is secondary prevention to prevent disease relapse, more in line with how we use vaccines for infectious disease. And based on these results, there's a phase 3 trial underway to prove whether this is really going to be helpful and enter the standard of care or not. So now we'll just turn our attention to immune checkpoints, which is what everyone's excited about. We're going to focus on 2 of them. This is part of that signal 2 that I talked about earlier. You can think of the generation of T cells in 2 phases. One is the priming phase, where they're getting educated by these orchestra leader type cells or the Pac-Man type cells. The other is the effector phase at the tumor site, where they're interacting with the cancer cells. So typically they're primed, they go to the lymph nodes, and then from the lymph nodes they go to the peripheral tissues. If you look here at the priming phase, here's the immune synapse. So this is signal 1 with the T cell receptor recognizing that tag in the context of self. The activation is B7 interacting with CD28, giving a positive signal. CTLA4 is its partner negative signal. If you block the interaction of CTLA4 with B7, you prevent the negative signal and allow the positive signal to proceed unsuppressed by CTLA4 activity. So there is a drug that's approved for melanoma called Yervoy or ipilimumab, specific for CTLA4, and it's used in the clinic for that. So that's one example. If you look at the effector phase, that's where the PD-1 pathway may be coming into play more. You get signal 1 here. Some tumors have a protein called PD-L1 on their surface. T cells have PD-1. When the T cells get to the tumor, the PD-1 and the PD-L1 can interact like a lock and key. And when they interact like a lock and key, they turn, it shuts the T cell off. Antibodies specific for either PD-1 or PD-L1 prevent the key from going into the lock, prevent that negative signal so that the positive signal stays and the T cell can more effectively lyse the cancer cell. So that's how we think that that works. This is an example of the activity of a PD-1 antibody in melanoma. This is called a waterfall plot. So any line above 0 is tumor cell growth. Any line below 0 is shrinkage of the cancer cells. Here's minus 100, so that's a complete response right there. So you can see that most of the patients actually can respond to this agent. It's just an antibody. This is called a spider plot for reasons that should be clear from just the way it looks. And time 0 is the tumor burden at baseline. Any line above 0 is tumor growth. Any line below 0 is tumor response. So you can see that these tumors can respond quickly to PD-1 blockade. Some tumors respond very well and have basically a complete response, as shown here. One of the really phenomenal things about these drugs is, in contrast to most immunotherapies, they can induce these fast responses. Most immunotherapies take a lot more time, but they last a long time. So you have this durability of the response, as shown by this flat line going all the way out over 2 years. So this is because of most likely immunologic memory. Despite the fact that these patients can respond and do well, there are some patients who don't respond at all. And one of our challenges is to figure out why that is and how to make these patients more responsive. Another unique feature of these drugs is sometimes the tumors can grow and then respond. So it's a little bit tricky to manage the patients because of this phenomenon of what we call pseudoprogression or late responses. This is just some CAT scans looking at tumor sizes. Here you can see a large tumor that shrunk at 8 months and shrunk more by 17. So these drugs are relatively well tolerated. The most common side effects people have on a day-to-day basis are things like you might expect with any drug: fatigue, rash, diarrhea, itchiness, lack of appetite, nausea. If you think about how these drugs work, they inhibit the immune system from becoming active. So one of the unique side effects of these kinds of drugs relative to chemotherapy is autoimmune type of side effects. And this can be very serious if you don't catch them quickly. Pneumonitis, or inflammation of the lung, is one example. Vitiligo, which is a depigmentation of the skin that T cells cause. It just causes destruction of the melanocytes that make the skin dark. So, for example, an African American would have white skin because of vitiligo, or spotty skin, kind of like Michael Jackson. Colitis, autoimmune colitis, which is manifested as pretty severe diarrhea. Hepatitis, thyroiditis, and this can occur in a large number of patients. And again, you have to catch this early because some of these can be life-threatening. But if you catch them early, they're manageable, and it's usually a good trade-off for the kind of response that you can potentially get with these drugs. So that's the overview of these drugs. And if you focus on the activity of them in breast cancer, there's 2 reports so far, and they're both in triple-negative breast cancer. Over here is an example of a breast cancer that's stained for PD-L1 antibody, and you can see that there's a ring of staining around these tumor cells, so there's PD-L1 expression by the tumor cells within the breast cancer. Triple-negative breast cancer is a particularly attractive candidate for cancer immunotherapy relative to other breast cancer subtypes for a few reasons. One is they tend to have a higher rate of mutational complexity. That means they may be more likely to induce an immune reaction because of the mutations, the mutational load in the tumor, which could lead to new tags or new antigens the immune system can more easily recognize. Triple-negative breast cancers are more likely to contain a lot of T cells, or TIL, that are PD-1 positive. It has higher rates of PD-L1 expression by tumor cells themselves. And particularly important, triple-negative breast cancer, as you all probably know, has no targeted therapy options currently available. We're only able to use chemotherapy because we don't have a good target. ER-positive breast cancer, we can use hormone therapy. HER2-positive breast cancer, we can use Herceptin and pertuzumab, lapatinib and Kadcyla and other things. But for triple-negative breast cancer so far, all we have in our toolbox is chemotherapy. This is data from the Keynote study of anti-PD-1 pembrolizumab in triple-negative breast cancer. These patients were relatively advanced and had 4 or 5 prior types of chemotherapy for metastatic disease. They were in pretty good shape in terms of their performance status, and their tumor had to be PD-L1 positive. 58% of all the patients evaluated for this trial were PD-L1 positive, and the drug was given every 2 weeks. The adverse events were similar to what's been seen in the past with this type of drug: a little bit of joint pain, fatigue, muscle pain, nausea, increases in the liver functions, a little bit of diarrhea, relatively well tolerated. A couple of autoimmune type side effects, hepatitis and hypothyroidism. Some serious things, a treatment-related death from abnormal clotting cascade, which can sometimes happen just with advanced cancer in and of itself. So these are the response rates. There were 27 patients, so small numbers, and the overall response rate was 18.5%, which is not as high as you would like to see, but still it shows that breast cancer can respond to an immune-based intervention. Response rates for melanoma are around 30%. Lung cancer is around 18%, so we're close to what they see with lung, and this has been approved in lung cancer. There was one complete response, 4 partial responses, 7 patients with stable disease, and then some with progressive disease. This is the spider plot, and like I said before, time 0 is the tumor burden at baseline. Some patients didn't respond at all, as you can see here. Some patients responded by 8 weeks and then had stabilization and just had these long, durable periods of stable disease where they continued to benefit from the drug. Some patients didn't objectively respond but had prolonged stable disease as a result of the drug treatment, as you can see in the middle part of the spider plot. So this drug has an acceptable safety and tolerability profile. I talked about the responses before. They're durable. That's really a unique feature of immunotherapy. 3 of the 5 responders were on therapy for 11 months or more. And there are advanced trials, both phase 2 and phase 3, testing this agent in patients with metastatic triple-negative disease. This agent targets not PD-1 like pembrolizumab, so this targets PD-1. This agent targets PD-L1, which is present on the tumor cell surface. And you can block the PD-1 pathway by blocking PD-L1. So this is a large phase 1 trial conducted in a variety of cancer types, bladder cancer, for which the response rate is around 50%. Melanoma typically has a response rate of about 30%. Non-small cell lung cancer maybe 18 to 20%. Kidney cancer is probably more on the lines of 25 to 30%. And then triple-negative breast cancer, and this in particular was PD-L1 positive patients. And this trial looked at PD-L1 expression on infiltrating immune cells, or T cells, as well as other immune cells. And there had to be 5% or more of those cells that were PD-L1 positive in order for the tumor to be considered PD-L1 positive. And this again is the spider plot. Some patients didn't respond, but several did with very nice responses. There was a CR, 2 CRs actually, and some partial responses. But again, this prolonged period of stable disease. The progression-free survival for this group at 6 months, 21 patients, was about 27%. This is an example of a response of a very large tumor that is growing out of the breast, and you can see that it shrinks very nicely during therapy. The tricky thing about these drugs is there can be atypical responses. So usually if you receive chemotherapy, and 2 months later you do a CAT scan and the tumor's bigger, you assume the tumor's progressed. With this, that's not always the case, and sometimes there can be a phenomenon of pseudoprogression where the tumor is bigger, but what the increase in size actually reflects is the immune system getting into the tumor and causing swelling. It's kind of like your glands when you have a sore throat getting swollen up. And here you can see with this patient there is a tumor at baseline. At 9 months, it's shrunk way down, and by 20 months, it's essentially resolved. You can see a second area of disease that is present at baseline and shrinks down. And you can see a third area where at 9 months, this third target had shrunk, but there's these new areas that are bigger. The patient was doing very well at this time, although this didn't make her very comfortable. But since she was doing well, we continued to watch, and she's continued on treatment, and those areas resolve. So this represents a form of pseudoprogression. This looks at TIL, or CD8 positive T cells, pre-treatment, which increase post-treatment, and PD-L1 expression, which is present pre-treatment and increases post-treatment. And these are tumor markers that decrease in the blood with treatment with this agent. So this anti-PD-L1 agent is well tolerated with fatigue, nausea, fever, decreased appetite, and just general not feeling well being the most common treatment-related events. There were 6 patients who had more serious events and 2 deaths that the investigator thought were related but were still under investigation by the sponsor. The response rate is about 19%. Remember, the other drug was 18.5, so it's similar. 24-week progression-free survival is 27%, so that's 6 months at 27%, no progression. Couple CRs, 2 partial responses, responses that are ongoing, and then you have this phenomenon of pseudoprogression where the initial disease has shrunk and new lesions pop up but eventually go away or are stable. And as a result of these data, this agent's now undergoing evaluation in a phase 3 randomized trial, testing PD-L1 with a control antibody or PD-L1 with Abraxane or a control antibody with Abraxane. So this is a very highly controlled randomized study that's going to really tell us if this can make a real difference as first-line therapy for metastatic triple-negative breast cancer. So what I've tried to show you is that just overall kind of some basic fundamental ideas about what the immune system is, what it's designed to do, and how it works. And then I focused on breast cancer to show you that cancers can be immunogenic, even those we didn't historically think could induce immunity. Standard cancer therapies like chemotherapy and monoclonal antibodies can help promote tumor immunity, so we need to think really carefully about how we combine these agents with standard therapies. Breast cancer vaccines are promising. With the excitement about immune checkpoint blockade, they're a little bit more in the background, but there are some tumors who have no T cells in them at all, and we're going to have to come up with a way of giving T cells to those patients through either a vaccine or adoptive T cell therapy or CAR T cells in order to make them more responsive to immune-based therapies. And PD-1 blockade, immune checkpoint blockade, is definitely arrived as a viable cancer treatment strategy and is emerging as one that's relevant to breast cancer as well. There's early data in ovarian cancer to suggest that this approach is also going to be active in ovarian cancer with response rates on the order of 10 to 12% for 2 different agents. And it's important to realize that the future really lies in immunotherapy combinations, pushing on the gas with vaccines to make more T cells, taking your foot off the brake with these checkpoint agents and other strategies, and really supporting the immune system by optimally integrating these strategies with standard therapies. And with that, I can take any questions that you guys might have.
Thank you so much, Dr. Emens. That was really incredibly informative. I've taken pages and pages of notes here. So thank you for that. So let me try to make sense of some of the questions that came in. So someone is asking if the good and the bad T cells are measured when someone gets a diagnosis of either breast or ovarian cancer. Is this common practice at this point?
It is not common practice at this point. It's a research area, and there is an effort out there to develop something called the Immunoscore to incorporate an evaluation of immune infiltrates at diagnosis into the staging of tumors, but it is not ready for prime time yet.
Okay. Someone was asking about an experimental form of immunotherapy called adoptive cell transfer, ACT.
Right.
Can you tell us anything about it?
So that's what I talked a little bit about when I said making T cells either by vaccines or giving T cells back. So there's a few ways that you can give T cells back passively, kind of like an antibody. So Herceptin is an antibody, so it's a form of passive immunotherapy where you're giving something that your body can actually make back, so the body doesn't have to make it. You can do that with T cells too. So you can extract the infiltrating T cells from a tumor and grow them up in the lab and activate them and expand them to large numbers and then give them back. Steve Rosenberg at the NCI has pioneered that for many years. You can modify those T cells to express a specific T cell receptor, so the T cells are genetically engineered. And then you have what's more recently been making a splash in the news called CAR T cells, where the T cells are genetically engineered to express a receptor on their surface that's more like an antibody with a signaling domain tagged onto it that are highly effective as well. So the challenge of adoptive T cell therapy is the practicality of it. You have to have very special laboratory systems for making the T cells, and it's probably something that's going to be available at very specialized centers, at least for the near future.
Mm-hmm. Okay, great. So the next question was about CAR T-cell therapy. And then along the same lines, ADCs?
Antibody-drug conjugates?
Yes.
So antibody-drug conjugates are very promising because the antibody acts like a guided missile to take a drug or a radioisotope or something, or a toxin, directly to where the cancer cells are. So from the antigen specificity point of view, the antibody is specific for those tags, and it's directly linked to the chemotherapy or the toxin or the radioisotope. There's an antibody-drug conjugate that's approved for breast cancer called Kadcyla. That's basically Herceptin linked to a chemotherapeutic agent. There's one also approved for leukemia. There's one that's under investigation for triple-negative breast cancer as well. So that's definitely an active area of research and actually clinical practice.
Great, thank you. So someone is saying they have stage 3 ovarian cancer, and at some point they've had a growth of MAC in the lung as a result of chemo. And she's wondering if immunotherapy would be a better option when and if she needs more treatment, and would it be available, or when do you think it might be available?
I mean, that's really hard to say without more specific details. A lot of it depends on the eligibility criteria for the different protocols, mm-hmm. and the rest of the history.
Mm-hmm. So someone is asking, I've read a little bit about PD-1 being used in ovarian cancer. Do you have any information about it, how successful it is, and are studies currently enrolling?
Yeah, I mentioned that at the end. I mentioned that ovarian cancer has recently been reported to have response rates of about 10 to 12%, so they're somewhat lower than some of the other tumor types. There are a number of clinical trials out there that are either imminent or are actively enrolling for PD-1 pathway blockade in ovarian cancer.
Great, and I'm just seeing if there are any other questions here. So a bunch of people are, asking, given their specific, diagnosis, would they be a good candidate for immunotherapy? I mean, it's hard for you to answer these questions.
Right.
But the broader question is that other than the drug that you just mentioned, there are no others that are approved yet for breast or ovarian cancer, correct?
Immunotherapies?
Yeah.
No. Just, Herceptin and agents that target HER2, they're monoclonal antibodies, so you can consider those immunotherapies if you'd like. But generally, PD-1 and PD-L1 agents and CTLA-4 agents are not approved. There's no vaccine that's currently approved. There's a lot of research going on, and everybody's pushing to get them approved. Mm-hmm. Hence these late-stage phase 2 and 3 trials.
Mm-hmm. And so, how do you know if someone is a good candidate for immunotherapy?
Well, there are,
what we're studying.
Most of the clinical trials, most of the clinical trials require a pretty good performance status, so you have to be in pretty good shape. It's better to do it not after you've tried 6 chemotherapies probably, but rather earlier on. The trials typically exclude individuals with a history of autoimmune type diseases because they may be at higher risk of serious side effects from the drugs just by virtue of the fact of the way they work. Typically, individuals who are on some type of steroid therapy are excluded from the trials. Those are the main things.
Great. I'm glad you brought that up because so many women with advanced cancers are excluded from trials based on previous treatments. And so, someone was wondering about, they're on first line now, they have been recommended to a second line, but you'd rather do immunotherapy. So is there any?
It's a very individual thing. It depends on
Right.
the clinical situation, and it depends on how the protocol is written.
But obviously, the fewer, the better.
I think it's better to use it, that's my bias, it's better to use it earlier rather than later.
Right. Okay, I think that's it. I don't see any additional questions here. Dr. Emens, thank you so very much. This was really incredible. Thank you for your time. And that's it. Thank you.
Okay, thank you very much.